Hey everyone, it's Dr. Locklear, and I'm coming to you today to talk to you about depressive disorders. And this is chapter 16 in your textbook, and it starts on page 378. So, we probably all, as individuals, have experienced some periods in our life of depression. Uh, Maybe related to a traumatic event, the loss of a loved one, or change in our life or our schedules, just different things. Just feeling bad physically can cause you to have depression. But when you have a true depressive disorder or the disease process of depression, you exhibit certain symptoms usually on a daily basis, and it makes life really hard to be able to function when you're in a depressive state. Again, like I said, we all have moments where we're depressed and we can get over it and move on, and we know how to deal with it. But people that are dealing with true depressive disorders and disease process, they have to live with this on a daily basis. So in our chapter on page 369, under the introduction, it talks about depression being one of the oldest but most frequently diagnosed psychiatric disorders, because so much can cause depression. Like I said, it can be a life event. Some people experience trauma and they never get over it, and then they're depressed the rest of their life. And so, uh, under this little description here, it talks about symptoms of depression can go back as just far as they can remember in the early documentation of mental health disorders. So this disease has been around a long, long time. Your objectives are listed here, and these are also on your course outline. I will not read these for the purposes of time, but please read these so you will be aware of what we're going to be looking at in this chapter. So, what is depression? Sometimes it's a feeling of having the occasional blues, feeling of sadness, or being kind of down, feeling low. Um, you know, Sometimes it's on a daily basis, or sometimes it can be after you have a baby, like postpartum depression. Sometimes it can be if you're female, during your menstrual cycle with the changes in hormones. Males can experience it with changes in testosterone. I know when my husband had open heart surgery, depression is a key factor with open heart patients, and he definitely did experience some depression for several months until he was able to get back to his normal routine. So again, it's the feeling of sadness or being downhearted, occasional, considered to be normal among healthy people. These episodes are short-lived. We adapt to loss, change, or failure. That's the key right there. We are able to adapt. And if we can adapt, then we would not be diagnosed with true depression. Pathological depression occurs when adaptation is ineffective and the symptoms are significant that impair our functioning. So, with true depressive disease and disorder, you are not able to adapt normally to stressors in your life. The stressors just continue to make you feel more and more depressed, which debilitates your ability to function. And so, as we get into this depressive state, it affects every aspect of the person's life, and sometimes to the point that they try to commit suicide because they feel like life is not worth living at that point. So, these patients are very high risk for depression. And if you're not able to see this video here, and I don't know why it's looking like this. Let me move to another screen and then I'll go back. Anyway, on the previous screen, if you're not able to view that video, just go to YouTube and type in "if I had a black dog," and it gives you a good example of depression. It is a little short clip you want to look at. So on page 375, 79, it talks about mood. Um, so what is mood? Mood is pervasive and a sustained emotion that may have a major influence on a person's perception of the world. Have you ever gotten up today in a particular day and thought to yourself, I don't know what kind of mood I'm in today? We all experience that sometimes. And then there's some days you're in a happy mood, you're in a depressed mood, you feel like crying, you feel like laughing, you don't feel like doing anything, or you feel like getting out and doing all kinds of stuff. Some examples of mood are depression, so feeling down, we just don't have no desire to do anything, no initiative, or you can feel joy. Joy is a mood. You're happy and you're excited and you're ready to, go out and do something. Elation, that goes along with joy. You feel elated, you feel happy, you feel good about yourself. Anger, you're mad, something has upset you, you're not in a good state of mind when you feel anger. And then anxiety, stuff just really affects you to the point that you don't want to deal with it, you're afraid of it. I have a big fear of snakes. I have a big fear of drowning. And when I'm around snakes, I get very, very anxious. So certain things can make us feel very anxious sometimes. I don't like to drive over long bridges. My anxiety just goes off the roof when that happens. And I'm sure you all experience different things as well. So another term you need to know, not just mood, is affect. And I've mentioned affect a little in another chapter, and it's how a person looks. Um, Look at the picture on the screen. If you as a nurse were to describe this person's affect, you would describe her as having a flat affect. Her face is flat. The muscles in her face are showing no emotion. Her eyes are fixed. Her whole structure of her face is just one solid picture. You see no emotion. So affect is the external observable emotional reaction associated with an experience. A flat aspect is someone who lacks emotional expression and is often severely depressed. And so, as a nurse, when you're documenting affect on your patients with depression, oftentimes you will document that they have a bland or flat affect, and you can use the word bland as well with that. So, what is depression? Depression on page 379 is described as an alteration in mood that is expressed by these feelings. Sadness. We cry sometimes. We're not always happy. Certain things make us feel down. Despair. We have no hope. Pessimism. We don't have any optimism. Everything is deemed as negative. You lose interest. You don't have any desire to do anything. You have somatic symptoms, and what these are physical symptoms that literally make you think that you're sick. People will throw up, they will have nausea and vomiting, they will have headaches, they will physically ache when there's really no uh, uh, definitive cause for these physical symptoms. You will have changes in appetite, sleep, and cognition. Basically, your appetite is poor. You don't want to eat. You don't sleep a lot. Your thought patterns are inhibited, and you can't always think clearly. I have a friend that has bipolar and depression and anxiety and personality disorder. She has multiple things going on, and a lot of times, if she doesn't take her medicine, she will stay up all night. She can't go to sleep. And she just has days where she's just wide awake and she just cannot shut down. So you will see some physical symptoms with depression as well. Our historical perspectives, in the biblical times, it was thought of as a supernatural or divine experience. Hippocrates believed that melancholy was caused by an excess of black bile, a heavily toxic substance produced in the spleen or the intestines, which affected the brain. This is a severe form of depressive disorder in which symptoms are very exaggerated and interest or pleasure in virtually all activities is lost. And so, back in his time, uh, this was the way he described it, that depression was coming from some type of physical perspective. And we do know that depression can be a imbalance of certain neurotransmitters in our brain, and we'll talk about that in a minute. Back to biblical, the Old Testament states in the book of Samuel that King Saul was depressed and he was inflicted by an evil spirit that was sent from God to torment him. And some people that are depressed do look at this from a spiritual aspect, and they do believe they're being punished by God. And when you interview these people, their thought processes are very focused on religious comments, and you just need to ask those open-ended questions. Tell me more. Tell me more about your thoughts and your feelings. But some of them will really feel like they're being punished. That there's a spiritual being that is punishing them, and this is why they're going through this. Okay, on page 380, we're going to talk about the epidemiology of depression. And of course, we know the word epidemiology means the background and the causes of this. So, MDD, this is a term that you'll see written in the patient's chart. So, if you see MDD, you'll know that is major depressive disorder. It is considered the common cold of psychiatric disorders. So what does that mean? It means that it's very common that millions of people experience depression in different forms. Some people experience clinical depression, and that's when you have a depressive disorder or the disease process. Remember, we all have depression, but we respond and react to it and adapt. But these patients cannot adapt. So major depressive disorder is considered the common cold. This generation is considered the age of melancholy, as we saw with Hippocrates. He really thought that there was a lot of physical things going on with within the physical realm. Um, so, how does age and gender affect depression? Research indicates that the incidence of depressive disorders is higher in women than it is in men by almost 2 to 1. And a lot of this is associated with our hormones, our thyroid dysfunctioning, and just the changes that we go through during the menstrual cycle, postpartum, and at menopause. Socioeconomic or social class, finances, and education. We know that people that come from lower socioeconomic backgrounds don't always have a good educational background. Plus, they may not even be able to work and have opportunities to seek out health care when they're exhibiting these conditions. Because there are therapies and medications out there that can help these folks get back to a normal state of mind. Race and culture, again, finances and education can be a factor because some economic classes uh, uh, you know, don't always have opportunities to, provide themselves with the education. And so, different races and cultures experience that. It talks about in your book that sample populations of non-white clients are often predominantly lower socioeconomic class populations that are compared with the white population from middle and upper class. So again, socioeconomic, race, and culture kind of go hand in hand, just from the fact that some people just don't have access to health care. And then marital status, it reports that marital stress is associated with increased risk for depression, suggesting that social stress may also be an important variable to consider. And we know that if you're in a marital relationship or just a relationship that is stressful, where there's abuse, mental or physical, the person that's being abused is often has a low self-esteem, and they feel very depressed within themselves because they can't pull themselves out of the situation. So they stay and allow it to continue to happen over and over, and it makes the depression even more difficult. Seasonality, this is happen. You see depression at different holidays because some people don't like to celebrate the holidays because of financially they can't afford to celebrate like other people. That's very depressing to people. Or they've lost loved ones, or they're alone at the holidays. A lot of healthcare workers experience depression during the holidays because they have to work and they can't be with their families. And then there's other reasons called related to demographic areas that have less exposure to natural sunlight. They're still doing studies on this, but there are some studies that say it's really not an issue. But there are some studies that do say people that live in areas that are cloudy and gloomy, such, like Alaska and places like that, that don't have, they have seasons of hardly no sunlight, experience a lot of depression in those areas. So on page 381 and 382, we're talking about the different types of depressive disorders. So you have major depressive disorder, and this is your MDD, and this is where you have depressed mood, you have a loss of interest or a loss of pleasure in the things that you usually enjoy. You are socially awkward and you don't like to be around a lot of people. You're very secluded. You like to stay in, don't like to get out, like to sleep a lot. You are not able to function in your occupation, and a lot of these folks lose their jobs. So you have impaired social and occupational functioning that has existed for at least 2 weeks, no history of manic behavior, symptoms that cannot be attributed to the use of substance or a general medical condition. And on page 383, is box 16-1, and it gives you your diagnostic criteria for MDD. And there's several things listed here. You need to read over these. Depressed for most of the day, diminished interest in things that gave you pleasure, significant weight loss, more than 5%, insomnia or hypersomnia, not able to sleep, psychomotor agitation, you just can't uh, there's times that you just can't be still, you're fidgety. Fatigue or weight loss, so there's times that you just don't move at all. Feelings of being worthless, you just have no self-esteem whatsoever, you just feel like you can't do anything right. Diminished ability to think, your cognition is altered, so make sure you read over that. Then in persistent depressive disorder, and this is termed dysthymia, this is your PDD. Mood is sad or down, and you're down in the dumps. Chronically depressed, irritable in children or adolescents for most of the day for at least 2 years. And your criteria for this is on box 16-2 on page 384. Depressed most of the day. Um, Persistence, presence while depressed, 2 or more of the following: poor appetite, you can't sleep, no energy, low self-esteem, you can't concentrate, just feel hopeless, nothing matters. And when you get to that point, these people will try to commit suicide because they don't feel like they're worth anything. They feel like life is just not worth living. It's very hard to pull somebody out of deep depression. So here's your criteria. Make sure that you look over that for that section. So on this page, we have MDD, major depressive disorder, and PDD, or dysthymia, persistent depressive disorder. Then it talks about your premenstrual dysphoric disorder. And this is where you experience depression or excessive anxiety, mood swings, and this is all during the menstrual cycle. And you see this, it most females are able to, deal with this and get over it once the menstrual cycle is over. This says this is on box 16-4, but that is in the prior edition. It is not in this textbook. Okay, I just wanted to mention that because it is a factor. But it is not on box 16-4 in this textbook. It's the prior edition. Then you have depression due to substance or medication-induced depression. This is a direct result of physiological effects of certain substances, such as anesthetics, analgesics, anticholinergics, anticonvulsants, antihypertensives, anti-Parkinsonian drugs, anti-ulcers, cardiac meds, oral contraceptives, because we know oral contraceptives, they alter the hormones, psychotropic meds, and these are the meds that we give for mental health disorders, and they can alter your mind state and make you have changes in your thought processes. Muscle relaxers, steroids, sulfonamides. So as you can see, there's certain medications that you can take that can cause you to feel depressed, but it's not true depression. Okay, you have to have the criteria for MDD or PDD, and these things are ruled out. Premenstrual substance or other medications, those or other related conditions, those are ruled out before depressive disorder is truly diagnosed. And then you have depressive disorder due to a medical condition. You may see patients that had a stroke and they are experiencing depression because they have a change in their cognitive status, or they're just down because they can't do the things that they used to do. On page 385, it gives you some examples of medical conditions that can influence depression: stroke, traumatic brain injuries, thyroid disorders because of the hormones, Cushing's, Huntington's, all of those are hormone-related disorders as well. Parkinson's disease, and multiple sclerosis, and those are issues due to your ineffective neurotransmitters not working correctly. So all these three have to be ruled out before depression can be truly diagnosed. Predisposing factors, this is on page 385 of genetics. You're very likely to develop depression if you have a direct family member that experienced depression. Biologic, when they did studies, there was a strong genetic factor in people who were twins. And then the neuroendocrine disturbances. You have issues with your hypothalamic, pituitary, adrenocortical axis, hypothalamic, pituitary, and thyroid axis. And we know that with the hypothalamic, this is in the brain. So you may have deficiencies of your neurotransmitters such as norepinephrine, serotonin, and dopamine. So medications that are used for depression are used to correct these imbalances in these three neurotransmitters. The thyroid and pituitary, these and adrenal glands, these are related to hormone-based causes. And so medications are used to correct the disorders. Like somebody with thyroid disease would have to take thyroid medication for that. And these are listed on page 387, the hypothalamic, pituitary, and hypothalamic, pituitary thyroid axis. I'm getting tongue-tied, you guys. So on page 387, we go to physiological influences. So this considers secondary depression, and it can be related to medication side effects, neurological disorders such as MS. People that have MS have issues with neurotransmitters, and they don't get the signal that they need, and it causes their muscles not to work appropriately. They become very debilitated, fatigued, and they get very depressed because they're not able to move around as much and take care of themselves and do their ADLs. You may have changes in electrolytes. Uh, we know that changes in our sodium and potassium and calcium and all of that affect our heart, and our heart can definitely affect our mood if it's not beating correctly and we're not getting perfusion. So, we need to be looking at these labs when we're working with these patients. And these patients, when they come in acute care settings, they do get a lab workup, and all this is looked at. Hormonal disturbances, we've already talked about that a little bit. Nutritional deficiencies, changes in your diet, not lack of certain vitamins can cause cognitive and neurological changes, which can lead to depression as well. Um, and then your book talks about physiological and psychological conditions as well. And it lists some diagnoses there for you. Also on page 388, under neurological, it lists talking about CVAs or stroke. It lists the different electrolytes that you need to look at, and it also lists the different vitamins that you would need to look at. Under all, on page 387, it goes into medication side effects, and here's another list for you, which is very close to the list that's listed earlier in this presentation. So just read over those. Okay. Medication side effects, and here again, these are listed here for you. And so just be aware that some of these medicines, they can cause depression because they affect the central nervous system. And then other predisposing factors, again, neurological, CVAs, electrolytes, hormonal, your vitamin deficiencies, and then other conditions and disease processes as well. And you see it, notice it's got syphilis. Syphilis, as it gets worse, really causes you to have almost like a dementia type state. You really lose your cognitive ability with syphilis. Psychosocial theories, these are on page 389, and it talks about Freud and mourning. And Freud presented his classic paper, Mourning and Melancholy, and here was his definition. Melancholy is a profoundly painful dejection, cessation of interest in the outside world, loss of the capacity to love, inhibition of all activities, and a lowering of the self regarding feelings to a degree that finds utterances in self-reproach and self-revelings and culminates in a delusional expectation of punishment. How severe? His belief was that you can get so depressed that you turn in towards yourself. You really hate yourself, and you look at yourself with a thought process of actually despising yourself. And truly, this leads. It's kind of sad because these people are severe, and it leads to suicide in most cases. Freud believed that the individual predisposed to melancholy experienced ambivalence in love and relationships, meaning ambivalent is you have no feelings towards it at all. It doesn't mean anything to you. He postulated, therefore, that once the loss had been incorporated into the self or the ego, the hostile part of the ambivalence that had been felt for the lost object is then turned inward against your own self. So if they have feelings, he thought, if I have a disregard for someone else, it can get to the point that I disregard my own self. And again, this leads to suicide. Then you have the learning theory, and this is learned helplessness. And it is a state that exists in humans who have experienced numerous failures, either real failures or they perceive themselves to be failures. The individual abandons any further attempt to succeed. They impose a feeling of lack of control over their life, and they become depressed because they feel helpless, and they have learned that whatever they do is futile. I couldn't help but always think about poor old Charlie Brown in the learning theory. He never could seem to do anything right, and he did experience some depression and had to go get counseling from Lucy for a nickel. It would be wonderful if it only cost that much because more people could get help. So also with the learning theory, people learn behavior from how they're raised. If they're raised in an environment where someone is severely depressed, they may exhibit that behavior because it's learned behavior. And so they often act the way that they see things. Another theory is in the learning theory is how people are treated. They come from abusive relationships, so they learn that they are made to feel worthless all the time. Object loss, this is the theory where they feel abandoned by others. They feel a significant loss. They feel that they have no one there. They feel that they have a loss of security and attachment, which leads to helplessness. And they feel this lifelong. They never get over that. You see this a lot with people that lose loved ones in a tragic accident or so. The cognitive theory, this is negative expectations of the environment, self, and future. And the primary disturbance in depression is cognitive rather than affective. Um, the cognitive theory focuses on helping the individuals to alter mood by changing the way they think. So when you go to have cognitive therapy, you're trying to get the person to think positive instead of negative. That's very hard to do. Some people you can't turn them around. And then you have the transactional method, and this recognizes the combined effects of genetics, biochemical, and psychosocial influences. So this is where you have someone that may have an underlying, truly physiological issue, like an imbalance in their neurotransmitters, but they also have been in an environment where the environment influences them as well. And so this is what you call combined. So developmental implications. So on page 388, you have box 16-5. Well, maybe not. It's probably in my older edition. Um, uh, Let me look and see where it is in this one. And there's not one in the new one, but we're going to talk about this. They just didn't add it in the new edition. And I am using the new edition. I should have taken that off. But when you're looking at developmental stages and ages, you really have to start in childhood. So up to age 3, and this is on page 390, signs may include feeding problems, tantrums, they're not playful, they lack the ability to show emotional expression, and failure to thrive. They're very labile babies. From ages 3 to 5, some of the common symptoms are they're accident prone. They're scared. They have phobias. They're very scared of everything. But then they can be very aggressive, and they can have excessive self-reproach for minor infractions. They really don't give any thought that if you punish them, it does affect, they don't change. From age 6 to 8, they may have vague physical complaints and display aggressive behavior. They cling to their parents, avoid new people and new challenges, and they do not do well in school, and they lack social skills as well. From ages 9 to 12, you see morbid thoughts. They think about killing themselves, and they think about killing other people, and they think about death and dying a lot. And they worry. They just worry about everything. Um, they may reason that they are depressed because they have disappointed their parents. They feel like that they haven't lived up to their parents' expectations. They don't want to play with friends. They lack social interaction. They like to keep to themselves, and they look sad all the time. They don't want to do anything. Um, when you see these symptoms, these children need to be evaluated. This is not normal behavior. The adolescents, they have feelings of sadness, loneliness, anxiety. They feel hopeless. Um, and it's hard to diagnose in the adolescent because when they're going through puberty and their hormones are beginning to come into play and it's changing their emotions and stuff, most parents or people will think, well, it's just being a teenager. And so, a lot of times adolescents will commit suicide because they were majorly depressed and no one was able to pick up on it because it was just deemed as normal growing pains of a teenager. Common symptoms in the adolescent are anger, aggressiveness, running away, they're delinquent from school, they're socially withdrawn, they act out sexually, the substance abuse, they're very restless, they argue a lot, they have low self-esteem, and because of this low self-esteem, they may try to do things that get people to think that they've done something really amazing, but in reality, they really have a low self-esteem. So their behavior can be very bizarre. They don't eat. They have eating disturbances. They lose weight. They look very thin and frail. And they complain of feeling sick, psychosomatic complaints. They're very apathetic. Um, they they just they just don't act like a normal teenager. They don't want to go be with their friends. They don't want to hang out. They don't want to ride around. They don't want to date. Um, they're just very self withdrawn. And then senescence or senescence. This is feelings of low self-esteem, helplessness, hopelessness, impaired coping strategies. The ECT, which is electroconvulsive therapy, is used for alternate treatment of major depression in elderly, especially considering the problematic side effects of antidepressants in this population. So, in sentences, this is when you're looking at the elderly, and they make up 14% of the general population. And a lot of these elderly folks, they are on medications that affect their behavior, and they do cause depression in this age group. Um, some of these are experiencing life changes such as loss of their home, their children, their spouse. They have to often go to a nursing home, and it really affects, how they feel about themselves, and and they just get more and more depressed. It's very hard to treat because, again, like I said, some of the medications that we use make the depression worse. And some people, because they're older and their body function has changed, they don't always process and metabolize medications like someone that is younger. So they may have the adverse reaction to a medication. So that can be an issue as well. On page 393, it talks about postpartum depression. You probably already had this in OB, so just go back and read over this. Postpartum depression is very real, and it can last from a few weeks to years. Some women become so depressed after having a child, they often commit suicide or they kill the child and themselves. Postpartum depression is very serious, and if it doesn't clear up in a few weeks, these people need to be evaluated. And if they are experiencing postpartum depression, even from the get-go, they need to be monitored to make sure that they're safe and the child is safe. Risk of suicide and infanticide is a problem, and it should be monitored and looked at. Being depressed after having a child is not normal, and it's related to a lot of hormone changes, and it can't be helped sometimes. Women, yes, they're very tired and fatigued, but most of the time they're very happy and elated that they've had a child. And so we need to look for these depressed moods, agitation, not wanting to hold the child, crying a lot, feeling guilty because they don't want to bond with their child. These need to be monitored very closely. Application of the nursing process. Before we get into that, at this point, you may want to stop and do this with all of my PowerPoints before you get into the nursing process. Just go back and do some reflective reading, and please take my PowerPoint and outline the material in the book that you need to go back and read along with my PowerPoint as well. That will help you. So application of the the nursing process starts on page 394. And of course, we always start with assessment. Box 16-4, and this is correct, on page 395, shows you the Hamilton Depression Scale. And you go through and you score, and will help determine if the person has a score that relates to depression, and then we can make the referral. The individual who is severely depressed may also demonstrate a loss of contact with reality. They may not know what day it is. They may not know who they are, their family members. They forget to eat, and they just don't realistically know what's going on. This level is associated with a complete lack of pleasure in all activities, and ruminations about suicide are very common. They think about killing themselves a lot. Symptoms can be described as alterations in 4 areas: affective, behavioral, cognitive, and physiological. So there are 4 types of depression, and this starts on page 394. And the first one is transient depression. And in this area, you have symptoms at this level of the continuum are not necessarily dysfunctional. In fact, they may be considered part of the broad range of typical human emotional responses that accompany everyday disappointments. Transient depression subsides quickly, and the individual is able to refocus on other goals. So affective, you feel sad, dejection, downhearted. Behavioral, you'll see some crying. Cognitive, there's difficulty getting your mind off of one's disappointment. Physiological, feeling tired and listless. I'll give you an example. Something was said to me this weekend, and it kind of bothered me a little bit. And I kind of had it on my mind all weekend. So this would be kind of considered transient. It really kind of got me down a little bit. But today, I'm fine. I've moved on, and it is what it is, and there's nothing I can do to change it, and so I've adapted to it. So that would be like a transient depression. Also under transient, under affective, you can have the blues as well. You just feel blue. You feel blah. You ever heard somebody say, I just feel blah today. I don't know why I feel blah. I just feel blah. The next one is mild depression. And with the affective, you see denial of feelings, anger, anxiety, guilt. You feel helpless, hopeless, sad, and despondent. Behavioral, you're tearful or crying. You have some regression. You're restless, you're agitated, and withdrawn. And that's what regression means. You withdraw yourself from your surroundings. Cognitive, you're preoccupied with the loss, self-blame, ambivalence, and blaming others. All you can think about is that particular situation. And then the physical, we may have anorexia, or we may overeat. We may not be able to sleep. We may have headaches, backaches, chest pain, and other physical symptoms as well. Let me go back. Okay. Moderate depression, this is on page 396, and I changed my screen too fast, and I can't stop it. So just stay with me on 396. So moderate depression. Symptoms associated with this disorder include in the affective, you're sad, dejected, very low self-esteem, difficulty experiencing pleasure. Behavioral, you have psychomotor retardation. In other words, you have slumped posture, slow speech, you're not moving, you're very sluggish, you look like a slug, as we describe it sometimes. Your cognitive, your processes are very slow. You have much difficulty concentrating. Physiological, the symptoms are even worse now, and you may go days without eating or sleeping. And then you have severe depression, and these two, moderate and severe, are pretty bad. The patient definitely needs help. They need to seek out clinical help, and they will not get any better if they don't get some clinical help. On page 397, you have um, nursing diagnoses associated with depression. Some of these will be on your test, so make sure that you read these. You can read these for yourself. I'm not going to read all of them. And look at the very first one, depressed mood, feelings of hopelessness, the nursing diagnoses, risk for suicide. Now, I know that you all have been taught for the last 2 years that risk for are not your priority nursing diagnoses. But in mental health, risk for suicide is a very high priority nursing diagnosis. Anybody that's on risk for suicide needs to be monitored to make sure that they don't carry it out. Because if I commit suicide, I don't need a care plan. It's over, right? So risk for suicide in mental health carries a high priority for nursing diagnoses. Okay, make sure you remember that. Severe depression, you're very low. Total despair, very low. Behavioral, you are just not you're not doing anything. You are just down for the count. Okay, there's a whole list of things under this section on page 396 for you. Very isolated, won't come out of your room, crying a lot. Um, Thought processes, you're delusional, you're having hallucinations, just beating yourself up. You just, I'm so stupid, I can't do anything right. You have nothing positive to say. Because of the low energy level and slow thought processes, the individual may be unable to follow through on suicidal ideas. However, even if they can't follow through because they're too weak, they still need to be monitored for suicide. If they want to commit suicide, they will find a way. And then your physiological, physically, you're completely worn out. You weight loss, anorexia. You're not sleeping. If you do sleep, you wake up feeling very tired, and you're just really down at this point. On page 397, it talks about your outcome criteria. So once we do our assessment, where do we want the patient to be? We've given them a diagnosis, and now what is the outcome? And all of these are listed there for you. They're all bulleted. The very first one, no physical harm to self. And then it moves into being able to pull yourself out of this, discuss your feelings, get over this hopelessness and helplessness, and being able to come up with a plan to learn to deal with it. Getting better with your diet and your physical well-being, bathing, changing clothes, sleeping 6 to 8 hours. Make sure you read over these because some of these will be on your test. Planning and implementation. You have in your care plan, your planning and implementation. And as I've told you before, I do take test questions from these care plans in this textbook. You need to know these interventions and look at the number one listed, risk for suicide. So as I said, in mental health, risk for suicide is a high priority. And ask the patient directly, have you thought about killing yourself? Have you thought about harming yourself? Do you have a plan? You want to create a safe environment. Remove everything that patient could possibly use to harm themselves. The patient has to be monitored very, very closely. They have to have one-on-one, frequent rounds. You're frequently checking on them. Most places do one-on-one with their patient. The second diagnosis is complicated grieving. So how do we help them deal with depression related to a loss? And you have numerous interventions here about using exercise, group therapy, developing a trusting relationship, communication. Let them cry. Let them cry. Sometimes they just need to cry and get it out of their system. The next diagnosis is low self-esteem, and you have five interventions here. And one of the things is you have to teach them how to accept themselves. And that's very hard to do, so they need group therapy. And teach effective communication, such as using I messages. I feel hurt when you say those things. So that will happen in group therapy and behavioral therapy as well. The next nursing diagnosis is powerlessness. How do we get them to get over feeling like they have no power? And again, you have to get them to group therapy, and they're taught ways to set realistic goals and not beat themselves when they don't meet these goals. They just reset new goals. The next nursing diagnosis is spiritual distress, and you have five interventions there. And then the next one is hopelessness, and you have six interventions there. Make sure you read over these when you're studying, because you will see some of these on the test. This is a very good care plan. And as you're getting to the point that you have to do a concept map and you do it on a depressed patient, please come back to these care plans in these books and let them help guide you on how to do your care plan concept. Evaluation, this is listed on page 398, and there are multiple bullets there for you. The biggest thing is, did the patient harm themselves? Have the suicidal ideation subsided? Are they able to set realistic goals and deal with grieving and take care of themselves? That's where you want to be. That's when you know that your care plan was effective and the patient is safe. Your book on page 403 talks about the treatment modalities for depression, and it goes into phase 1, 2, and 3, and then it goes into group therapy. And so since we're on the slide for group therapy, I'm going to go ahead and talk about that, and I'll come back to the phases. Group therapy, this is on page 405, and this is where you take the patient to groups where they can talk to other people that are dealing with depression, and they can share ideas on how they deal with it and how it's affected their life. One good thing about group therapy is it lets the patient know that they are not alone, and it gives them a feeling of security and a feeling of hope. So they're usually peer-led, and they don't take the place of what medications can do. It's a combination. Group therapy is not going to fix it all. They may need some medicines. So there's going to be multiple things that they do. Family therapy, you want to get the family involved as well, and this is on 405 as well. You can read this. Cognitive therapy, this is where we want to change their mindset. And look at that on page 406. It talks about some examples here of automatic thoughts. Personalizing, I'm the only one who failed. All or nothing, I'm a complete failure. Mind reading, he thinks I'm foolish. And then discounting positives. The other questions were so easy, any dummy could have gotten them right. And so in cognitive therapy, we have to look at a way to change their automatic thoughts. We have to help them develop a process. And you guys, this is not easy. Some patients do not get anything out of group cognitive therapy because the patient has to be willing to think through these things and change their mindset when they get depressed. For example, when they're depressed, cognitive therapy would teach them to say, okay, this is depressing me. What do I need to do to pull myself out of depression? How do I get this off of my mind? Do I go take a drive? Do I go cut my grass? Do I go talk to a friend? Do I read and meditate? What do I need to do to change my thought processes and get my mind off of what's depressing me? And so that's cognitive therapy, ways to change the way you think about what's causing you to be depressed. And one of the things with these automatic thoughts, and they teach them, instead of saying negative things, say positive things about yourself. Well, my hair looks good today. I look good in this dress that I have on. I ate all of my breakfast today. Okay. Positive thoughts. Positive thoughts. Electroconvulsive therapy. This is ECT. This is on page 407, not 405. It's the induction of a grand mal seizure through the application of an electrical current, and then this seizure is supposed to kind of jumpstart or reset the neurotransmitters. It is effective with patients who are suicidal and severely depressed, and it can cause temporary memory loss and confusion. Some of the risks associated with ECT are mortality. It can cause acute myocardial infarction, which can lead to death, and a CVA. You can have permanent memory loss and brain damage. Before we get into the pharmacology piece, let's go back to page 403 and look at the phases. So treatment modality for depression, individual psychotherapy, and it's done in phases. So in phase 1, the client is assessed to determine the extent of the illness. Complete information is given, and the client is encouraged to continue working and participating in regular therapy. They need to go to therapy. A lot of times they'll start therapy and they won't finish it. Phase 2, this focuses on helping the client to resolve complicated grief reactions and resolve ambivalent feelings due to a lost relationship. It teaches them how to establish new relationships and role transition. Phase 3, this is the final phase, the emphasis on reassurance, clarification of emotional states, improvement of interpersonal communication, talking to yourself, self-talk, testing of perceptions, and performance in interpersonal settings. So in phase 3, they're looking at how you are doing with positive self-talk. Are you able to talk yourself out of the situation? And that's a good thing. Okay, now let's go to page 409, and this starts our psychopharmacology. And of course, we're going to give drugs that are called antidepressants. And these include your tricyclics, tetracyclic, heterocyclic, your MAOIs, your SSRIs, SNRIs, and then combination drugs as well. There is a chart on page 411 that lists all of these medications. If I ask you any questions about medications, it will be general stuff like education and things like that. One particular medication is the ketamine. Make sure that you read over about the ketamine as well. Client and family education, I do have some questions about that. Continue to take the medication even though you feel better, because it has to stay in your system and stay therapeutic. Use caution when driving because it does make you dizzy. Do not continue abruptly because you may go into withdrawals. Use sunblock because it causes photosensitivity. Immediately report occurrence of any of the following: sore throat, fever, yellow skin, headache, so forth. Rise slowly because it can change your blood pressure. Take frequent sips of water because it causes dry mouth. Sugarless gum, hard candy if the patient can have that. Do not consume the following foods or medications while taking MAOI inhibitors: aged cheese, Chianti wine or Chianti wine, beer, chocolate, colas, coffee, tea, sour cream. Cheese and foods with caffeine in it can cause a life-threatening hypertensive crisis. Make sure that you look at this list here. You will see test questions about this. Avoid smoking, especially with tricyclic medications. Avoid alcohol with any antidepressant therapy. Avoid use of over-the-counter medications such as cold medications, medications to help with allergies, like anticholinergic medications. Notify the physician immediately if you have a prolonged penile erection, usually lasting longer than an hour. That is an emergency. Do not double up if you miss a dose. Follow the correct procedure for applying the selegiline transdermal patch, and that's at the bottom of page 410. This comes in a patch, and you need to follow these guidelines when you're using any kind of patch. Apply the patch at the same time each day. Wash your hands thoroughly after touching the patch. Avoid exposing application site to direct heat, and you need to change sites when you're using any kind of patches. Okay, so make sure that you look at all of these. All right? And then there's some practice questions here for you at the end of my PowerPoint, so you can practice. There's also practice questions at the end of your chapter. And one thing that is fascinating about this book, and I love this, on page 417, and this is in every chapter, you have movies that you can watch that relate specifically to depression or schizophrenia. One in particular for depression is The Prince of Tides. Was a very popular movie at one time, which I know you really don't have time to watch movies, but I thought, it's fascinating that our book does this. It also gives you some case studies on page 417 to check your own knowledge. But I highly recommend doing these practice questions and reading over these case studies as well at the end of the chapter. But here are your NCLEX practice questions, and I have a total of, I think, 5. Let me go through all of them. You're going to get a copy of my PowerPoint beyond this recording.